Okay, so we continue our presentation with carrion. What is carrion? Carrion is an abscess caused by fungal infection. Okay, so most often it occurs on the scalp, but it can also occur in other sites. And it is often misdiagnosed as bacterial infection. So the feature is usually an elevated boggy appearance with history of tinea capitis. It is quite obvious in this picture where you can see an area of alopecia caused by tinea capitis, fungal infection of the scalp. But then in the middle, you have this boggy raised area of abscess, which is caused by fungal infection. So many times, I see patients who come with carrion was treated with antibiotic for some time, and patient complains that the infection does not resolve. Why the infection does not resolve? Because it is not bacterial infection. It is a fungal infection. So what you need to do is to prescribe oral antifungal, quite a long duration of antibiotic treatment, can be up to 6 to 8 weeks of either itraconazole or terbinafine. So since this is abscess, then topical antifungal would not be effective. So remember, these are some of the types of abscess that is usually misdiagnosed by doctors. Next is tinea incognito. Basically, tinea incognito is just a tinea infection, can be anywhere. But then, because of inappropriate treatment, usually by topical steroid, it has less features of tinea infection. Sometimes we wouldn't know whether this is tinea infection or this is eczema. But the feature probably in tinea infection, the border usually is well defined. Yeah? And you can see there some scales, silvery like scales. So that could be a clue that this is tinea infection. It can be also psoriasis, but doesn't look like psoriasis that much. But you may confuse yourself with either eczema or tinea infection. Okay, so just what like I said just now, if you're not sure, you send for skin scraping. If you don't have the facility, then you can continue to treat as tinea infection first, then only eczema. Okay, sporotrichosis. Sporotrichosis is caused by a fungus, Sporothrix shankii. Basically, it's just a name of the fungal infection of the fungus organism. Okay, so usually the history is because this organism is found in the soil and vegetation. Usually there is a history of cuts, scratches or punches when working with soil. For example, farmers, nursery workers, landscapers, gardeners. This is a typical history when you see a patient. Most of my patients who come with sporotrichosis, they will have this type of history doing gardening. Okay, contohnya saya luka masa apa masa gardening, masa berkebun. Okay, tercucuk dahan or pokok. That is the typical story. And then the patient are typically well without fever, but then the lesion develops at the site of scratch. And then the typical feature is you can see nodules appear under the skin along the lymphatic channel, usually in the hand because they are using their hands to do the gardening. And this lesion actually painless or sometimes it's just mildly tender, and then it becomes the nodule becomes bigger, reddens, and sometimes pustular and ulcerates. And most cases it spreads from the distal to proximal, so the nodule develop one by one from distal to proximal. This is a quite a typical features of sporotrichosis. And many of my patients come with this type of picture. This type of picture. This type of picture. This is a typical picture of sporotrichosis. And similar to carry on, many of my patients actually complain that they have been going or receiving treatment from so many places with different types of antibiotics, but it does not work. Why it does not work? Because it is fungal infection. It is not bacterial infection. So antibiotic won't work. So what you need to do is basically for sporotrichosis is oral antifungal agent. I will discuss later in a bit. So in general, treatment for antifungal is prevention. Avoid sharing clothes. If you know that other patients have fungal infection, so don't share any clothing with them. Okay. You can use topical antifungal cream or antifungal shampoo, and sometimes you may need oral antifungal agent. So antifungal cream, which is mostly which are mostly used, are miconazole cream, clotrimazole cream, and you usually apply twice a day for and continue for 14 days after the lesion have healed. So you have to inform the patient, you have to apply this antifungal cream twice a day until the lesion disappeared. But then after the lesion has disappeared, you have to continue for another 2 weeks to prevent recurrence. Okay, so for oral antifungal, you can use azole group of antifungal. The most common ones are itraconazole, ketoconazole, terbinafine, fluconazole, and fluconazole. Okay, ketoconazole is cheaper than itraconazole, but ketoconazole has more side effects, especially hepatitis. It can cause deranged liver enzymes. So itraconazole is actually safer, even though it's more expensive. So the duration of antifungal treatment depends on what types of lesion it is. For example, like just now I mentioned, if it's nail or fingernail or toenail infection, it can be between 3 to 6 months. If it is just tinea, extensive tinea corporis, probably you can use for 7 days. Pityriasis versicolor, panau, yeah, it's quite common. You can treat for 7 days. You can also use terbinafine, but usually terbinafine we reserve it for like nail infection. Fluconazole also you can use for tinea infection if it is available. Okay, so for sporotrichosis, I mentioned just now, it needs quite a long duration of treatment. So itraconazole 200 milligram until 2 to 4 weeks after all lesion have resolved. So it takes quite some time and can be up to 3 to 6 months. So it's a bit long duration of treatment for sporotrichosis and the nail infection, nail fungal infection. So this is about all of fungal infection. Just like what I told you about dermatitis, sometimes you may not know what type of dermatitis it is, but usually the treatment is the same. Similarly, in fungal infection, you need to have the ability to differentiate and pick up the feature of fungal infection. You have to look back at the feature of fungal infection, and treatment is with antifungal. Usually it's an azole group. If the fungal infection is not severe, it's not widespread, just local infection, you may use topical antifungal cream. But if it is more extensive or widespread, or if it is a nail infection or carrion or sporotrichosis, then you may need oral antifungal treatment such as ketoconazole or itraconazole or terbinafine. So basically that is about it for the treatment and management of fungal infection. Another problem with fungal infection is you have quite severe itchiness. So you can give antihistamine. Like I mentioned just now, you can use whether sedative or non-sedative antihistamine. Piriton, Atarax. For the sedative one, you can use loratadine, desloratadine, or Zyrtec for the non-sedative one. And then it depends on the patient whether it is suitable to give the sedative or the non-sedative one. So basically, fungal infection, it's easy. It's not that complicated as long as you can identify that this is fungal infection. Okay, that is about all about fungal infection. Thank you very much. Good luck for your exam.